Hi, everyone. Welcome. Thank you so much for joining us today for our webinar on the importance of patient-oriented research. My name is Kelly Giesbrecht, and I'm stepping in for my colleague, Jeevan Sangha, who is unfortunately not well today and not able to host. So I'm happy to be here with you today. I'm joining from the ancestral, traditional, and unceded territory of the Lheidli T'enneh. And I welcome you to take a moment to acknowledge the traditional territories from which you are joining today as well. Also, please feel free to say hello in the chat and let us know where you're located. And if you want to include your land acknowledgement, that would be great. In terms of what we have in store today, we have an amazing session ahead. So I really invite everyone to take a moment to be present in this space and engage in this session and the conversations and activities that we have for you. If you have any questions or comments during the presentation, please feel free to pop them into the chat box and we'll get to them during the question and answer portion of the session after our speakers have taken the floor. We also want to remind you that we will be spotlighting our speakers, and if you're having trouble seeing who's speaking, maybe just go up to the gallery view and switch that around until you can see the speakers, and we'll also be sharing some slides, so that will be important to do. Without further ado, I'm going to turn the floor over to Krista Lamb from Diabetes Action Canada to introduce herself and our speakers today. Over to you, Krista.
Thank you. It's really wonderful to be here today. I am Krista Lamb. I am an author. I'm a podcast host and producer and a science communicator. And I also have the distinct pleasure of being the communications lead at Diabetes Action Canada. And I'm really excited to bring you some stories and to introduce you to some of our members today. So first, I'm going to introduce the amazing Tracy McGuire, who is the Executive Director of Research Operations at Diabetes Action Canada. She brings more than 15 years of research project and program management experience, as well as research operations and strategic planning expertise. So we are so happy to have the brand new Executive Director of Diabetes Action Canada here to chat with us today. So Tracy, I will give you the floor.
Thank you, Krista, for that amazing intro, and I'm really excited to be here today. I'm just going to share my screen now and make sure everyone can see my slides. My point today, and just everyone can see my slides all right? Yes, okay. Really, the main goal of my talk today is to inspire patient engagement in research in all pillars. And so you're going to see some of the lessons that we've learned and how patient engagement can be applied into research in the research infrastructure. And I'm really looking forward to discussing with you today about how to do that and how Diabetes Action Canada can help in this process. So what is Diabetes Action Canada? We are a national diabetes research network with 217 members, and these members include not only researchers, but patient partners. So nearly half of our members are patient partners. We have research programs that are developed from patient partner input, which means that our network is entirely driven by the feedback that we receive from people who have lived experience in diabetes. Our goal is focused around finding those areas that those living with diabetes are affected by most. And our network is about preventing complications. So I just want to actually make that very known. There is a large field of research that does look in prevention of diabetes, and that's type 2 diabetes only. Our network looks at preventing diabetes complications. So we look at type 2 diabetes complications prevention, as well as type 1 diabetes complication prevention. And I just want to make that clear because we all know that type 1 diabetes cannot be prevented. We are funded by the Canadian Institutes of Health Research, so CIHR, and all of that money that was is matched by philanthropic support. So that is how our network is funded. So this is just an infographic about how our network is constructed. As I mentioned, we have 97 patient partners. We have 29 partners. So this includes academic institutions, strategic partners, and those are people who have, or organizations such as JDRF and Diabetes Canada, who have worked with us in their patient-oriented research journey. We have researchers and patient partners in 8 provinces. We have 120 researchers across those 8 provinces, and we have 10 programs of research. But really, The heart of our organization is in our patient partners. So here are just a few of our patient partners, all who have very important leadership roles within our organization. Two of whom you're going to see here today. So many people ask, why do we do patient engagement? We're starting to see patient engagement really emerge as an area of interest for a lot of peer-reviewed grants, a lot of opportunities with working with governments and other institutions. And so many people might not actually understand why patient engagement is so important. And it is really important because patients are actually people. I know it's hard to believe, but they're people who are experiencing the health system while they're actually experiencing a health crisis. And so they're experiencing the health system in a way that we as people who work or study the health system don't necessarily realize. And they can identify the gaps way better than we can. So their experiences go beyond living with the condition, but also their experiences in talking with doctors, healthcare professionals, accessing care. So it's really important to learn from them some of the gaps or areas that we can improve. They have the best feedback on where we need to focus our research. And in fact, it is proven that if you do a patient and community engagement strategy in research, you will identify priorities that not only hit specific gaps, but also are retained and applied within our healthcare system. The research is more relevant and useful and patient-centered, which means that you are truly getting to the crux of the matter. It increases the uptake of new evidence, so I just mentioned that, and it reduces wasted resources. So patient engagement has definitely been a journey for organizations. So Diabetes Action Canada started about 6 years ago in our first funding term. So we are now in our second funding term. In our first funding term, it was all about establishing a patient-oriented research network in diabetes. So that's where our main focus was. And in those 6 years, we learned a lot about what we do and what we don't do. And I can't even talk about these next slides without acknowledging all the hard work done by our patient partners. So we have a really robust patient partner engagement strategy that includes 3 circles. And these circles together came together to create these do's and don'ts on what they've experienced within our network on how to appropriately engage patient partners in research. So these do's and don'ts that I'm going to go through today were actually crafted by 3 patient partners. So I'm going to say Donna Greenberg, Virtue Aberjuni, and Sasha Delorme were instrumental in putting these together for us. And I want to make sure that they're appropriately acknowledged. So one of the first things that really came through when we were talking about the do's and don'ts of bringing people into research is that we have to treat patient partners as equals within a research structure. And this seems like it is simple enough of a tactic, but we do find that sometimes it's hard for physicians who are normally used to being addressed by their salutations, like Dr. So-and-so, Dr. This and that. And that can create a power dynamic that might lead to discomfort from patient partners and their ability to truly express how they feel. So one of the things that we've really learned is that we have to make sure everyone is an equal in the room. So we leave our salutations at the door. Nobody's better than anyone else. And we're just there to discuss an issue and a problem. So this has become a real mantra for us, is that everybody is equal. Doesn't matter how many years of school you went to, we all have a vested interest in finding a solution. Number 2, the patient partners do not want to be included in a tokenistic manner. So this actually becomes very interesting, and something we've observed as well, is that patient engagement has become a real key theme in a lot of peer-reviewed funding. But oftentimes Diabetes Action Canada will actually get a request for patient partners really late in the process of planning research, and just to have someone on the grant. And this is where it becomes a bit of an issue, because people who are patient partners never actually contributed to the body of work. And so now we actually make sure that patient partners are there from the beginning. So we won't necessarily connect people when it's like 2 days before grant deadline, oh, I need a patient partner, because that patient partner has not actually said anything and they're on that grant as a token. So how we do and how we work with our research teams within Diabetes Action Canada is we find we start from the beginning. We work within right from the calls of research, and we talk to all of our members to find out if they're applying for grants and how we can get patient partners involved from the outset. And then clearly stating the expectations from the beginning of the project. So this becomes, again, an issue where people engage patient partners, but may not necessarily have that, intro meeting that sets mutual understanding on how this project will be implemented. And it becomes a real problem when people are signing up to do a couple of hours here and there to consult on a project, and then they get overburdened by requests from research teams. So it is really important to establish that shared and that mutual understanding from the get-go. So I already mentioned this, but I think it deserves repeating, and that's involving patient partners from the beginning. So as I said, we often get these requests really late in the process, and it turns out that it becomes a tokenistic look at patient partners. We really want to make sure that that's not how it goes, because the patient partners are supposed to be there to help decide priorities for research and help form research questions. And then don't waste patient partners' time. So that means that it is very hard to know when you're actually wasting a patient partner's time and not actually using them effectively. And that's where that first call of establishing a mutual understanding is really brought into play. We want to make sure people understand what kind of expertise is coming forward and how people can be best used for that expertise. And so we don't want to engage people in activities that might not necessarily be within their expertise and therefore wasting their time. And carefully considering the number of patient partners you want to involve in a project. So this is interesting, again, going back to tokenistic patient engagement. Some researchers or people who are looking to engage patients think that only one is enough. But that shared experience of one person won't necessarily, that lived experience of one person might not be shared by many. And so it is important to actually get people from different groups to try and understand if that same experience is shared amongst multiple groups, regardless of where they live, what their social determinants of health are, or any other contributing factors. Keeping the communication open and ongoing. So researchers forget that not everyone knows that the research process takes a really long time. So, from the time a research project is actually conceptualized to when you apply for grants and when you actually get that funding and then do that project, that can be years ongoing. Now, when people contribute to research, especially in the planning process, it is expected that there is more of an immediate response to their contribution. And because it's not necessarily the case, because research does take a long time, it's important to keep the communication open and ongoing. So keeping people informed, making sure everyone knows what stage the research is at, whether it be at the application stage, at the review stage, at the funding stage, or the implementation stage. And this really keeps people engaged for when they do need to be reactivated in their patient engagement, so that they know exactly where the project is at any given time. And then refrain from using jargon and acronyms in communicating with patient partners. And I think this goes for everyone in research and anyone who's experiencing a new group within research. And I can say for myself, I'm a very entrenched in the diabetes space, but when I sit in meetings with cardiologists, I don't necessarily know what they're talking about if everyone's speaking in jargon and acronyms. So we do make sure that every time we speak, we always speak with full definitions, unless the acronym is well known amongst the group. And if there is ever a time, we want to make sure that if there's ever an uncertainty, we want to make sure everyone understands what that acronym stands for. Make space for patient partners to speak up. So we invite patient partners a lot to meetings. Initially, we didn't necessarily give them the time on the agenda to really speak their minds, give their opinions. And then it was left to the end of the meeting to be like, does anyone have anything else to say, expecting patient partners at that point to put up their hand and contribute. That doesn't necessarily work for all. And we've learned that now that there has to be a part on the agenda, typically at the beginning and in the middle and at the end, to give people a time to respond to what's been discussed. So this is a really important opportunity for patient partners to see that they are indeed included as active contributors to the research process. And then finally, materials and event spaces must be accessible. And this is really important, especially as we talk about some of the complications that can be experienced for those living with diabetes. We have many patient partners who live with diabetic retinopathy, who might not be able to read a PDF because their readers require a Word document for that. Or there might be people who are experiencing a foot wound or a foot problem, and they might not be able to enter a building with stairs. So we have to consider all of these when planning to have in-person meetings or planning to share materials amongst our groups. Oh, sorry. So a lot of people ask me again, when and what functions can patient partners serve at the various stages of research? So I put this slide together. We've seen it in many different iterations. I've done it linear with the expectation that just for the explanation here, but we all know that the research process is quite circular and that it restarts every time a project is conceptualized. So really at the research priority stage, that's when we want to bring in our patient partners to make sure that we can have focus groups to really plan out ideas, to really, soundboard things. Are we really hitting on the right area of the complication? Is there anything that we really want to investigate, given that there's this funding opportunity available? So these focus groups are pretty small. We run them at Diabetes Action Canada. They can be up to 5 people. Usually an investigator is there, but only as an observer. And we're really just listening to people to find out what area we should be going or what direction we should be going in for each of our projects. This is also a really important opportunity to onboard new patient partners in the research process, because they might not actually know. They might have gone through patient-oriented research training, which is a requirement for all our members, but they might not have actually experienced it. So it's a good learning opportunity. In the research design and planning, there's the feedback process. So, there's a lot of times where people will put proposals together. We need a feedback from our patient partners. We need feedback on the deliverables that might be conceived in the project, or feedback on the research implementation. Like, is the study designed too burdensome for a patient participant with somebody who needs to go to the hospital in person 3 times a week? Is that reasonable to ask in order to achieve the research outcome? So this is where we hear really important aspects of what we can do to improve our research. And then research implementation and operations, we have patient partners on all our governance committees, on all our patient advisory committees. So even though patient engagement happened at the beginning and in the conceptualization of the research itself, there also has to be these checkpoints where patient partners come in and actually check to make sure that people are reminded that there is this feedback from patient partners throughout the implementation, throughout how they expect to carry out the research, how they want to publish. And so this advisory committee is really important to help keep the patient perspective ingrained in the project. The communication and dissemination part, that's really about knowledge mobilization. And that's how we take the research outcome out of the academic space and bring it more into the lay audience space. This is an area that we really need to improve on in every area of science. Diabetes is not an exception here, but we really rely on our patient partners to help us review some of the materials that we put together and really make it digestible and accessible to all reading levels, to all populations, and so that it's really easy to understand. There's also that buy-in through social media. And, Chris has taught me so much since she's been the lead of our communications about the importance of social media and the amplification of some of our messaging through patient partners who might be really connected amongst other patient groups or patient advocacy areas. And actually, that is one of the main strengths of having a really high social media presence with our patient partners. They're able to really transmit that message way beyond what we could do alone. Now, sharing research outcomes, I've already touched on this, but I think it's important that we also want to take our research out of those, really literary or academic published spaces and try to get them more into lay press spaces. And so our patient partners has helped us in that as well. And then finally, in the monitoring and the evaluation of our research, our policy development, patient partners are often encouraged to be participating with policy and decision makers, and especially if they were actual participants of the research process. They are way more effective at advocating for change if the research outcomes indicated that was a way to go, or if the research outcome was about influencing clinical practice guidelines. Having a patient partner advocate there who experienced the whole process is very powerful. They're also really important about planning future research. And then that's where this becomes a circular diagram. So not only do they help us plan for future research, but they also mentor their peers so that we can do this again and over with new patient partners, or with a mix of new patient partners and patient partners who've gone through it a few times. So then everyone's building capacity within the research space of patient-oriented research. So how we formalized our patient engagement program is we have 3 patient circles who are established. Now these each represent a core group within our network. So we have our Indigenous patient circle, and you can see where those orange lines indicate our areas within Canada that our members come from. We have our Francophone and immigrant patient circle. So these are people who come to Canada who can speak French, but French is most likely not their second language, first language. It's somewhere down the line. It might even be their 4th or 5th language. And how they experience the healthcare system is actually quite different than how somebody who is a Francophone first language. So I would say you can see that group is mostly from Quebec. And then we have our collective patient circle. And this circle is really our one of our well, it's our circle that comprises most of those individuals with different lived experiences of diabetes from across the country. So if people who live with type 1, type 2, they're from all across the country, they're from different ages, different groups, different regions, and really they represent our core area of consultation whenever we're trying to create any new policy or trying to brainstorm new ideas for our network. I can say that this whole concept was actually derived from a publication, and this publication is just here in highlight. And our whole network was a questionnaire that was distributed to many people living with diabetes, both type 1 and type 2, pre-diabetes, MODI, LADA, all of those individuals who experience some type of diabetes experience. And they put together their feedback, and from their feedback, we created our network, including how we should structure our circles. Our patient engagement, how? So Diabetes Action Canada is the main catalyst. We have about 97 patient partners. We recruit these people from all across the country in different regions and areas from populations that are most impacted by diabetes. We help recruit these members to research opportunities, and we monitor the process to make sure that everyone's experience, both the researcher and the patient partner experience, is positive. And then patient partners are compensated and appropriately acknowledged for their work. So we have a compensation policy that we stick to quite stringently, and we actually ensure that all of our acknowledgements are appropriate, whether it be in publications or acknowledgements by researchers on publications or in our social media areas. So the sampling of our programs, I talked about how we were looking at some of our complications. Here are just a few. There are 10 in total, but the ones that really work in specific areas are Indigenous health, older adults with diabetes, type 1 diabetes, preventing blindness, amputation prevention, mental health, and the use of health data to improve diabetes experiences. So I'm told I'm running over time, but here is our email, here is our website and our email address and our Twitter. So if you want to learn more, you can go to any one of those areas and ask for anything.
Thanks, Tracy. That was amazing. I really enjoyed that. And I wanted to point out to anyone who is watching live that you can put your questions into the chat. We will try to get to all of the questions at the end of today's session, but we can also try and answer them as we go along. So definitely keep putting your things into the chat. And now, Tracy, if you could just stop sharing your screen, that would be awesome. Perfect. So now I am going to introduce our next speaker, who is Mike Alexander. And Mike is one of our patient partners. He is an Anishinaabe artist, an athlete, and he has been such a wonderful inspiration to me. I always enjoy the chance to talk to him. So I'm looking really forward to this. We're going to do this in a chat format, which is what I'm really comfortable with as a podcast host. So I hope that you guys will enjoy this too. So Mike, welcome. I'm so glad that you are here with us today.
Oh, I'm happy to be here as well. Thanks a lot.
And you are one of our BC patient partners, and you lived with type 2 diabetes. And I would love to know a little bit more about your diabetes story, if you don't mind telling us.
Yeah. So when you are Indigenous and you do not live in your community, when you don't know your language, when you don't know your culture or even your biological family, that causes an awful lot of problems emotionally and physically and mentally, right? That's a complete disconnect from culture, and that's kind of how my life started at a young age, being a part of the 60 Scoop here in Canada. So for a long time, I didn't realize that that was going to be a big problem for me. Denial and active addiction sort of kind of work hand in hand to sort of you know kind of told me that it's okay. Like I'm not a I don't, I mean, I didn't know what trauma was at the time, you know? Um, so, Fast forward to being well into my 30s, um, you know, just kind of in really bad shape, suicidal ideation that I acted upon, just kind of, major depression, and just kind of in a bad way all around, right? So, when I moved to BC 7 years ago, I linked up with a nurse practitioner who helped me change my life. And for the first time ever, I started to trust someone within the healthcare, world. Back in Winnipeg, it wasn't a really positive experience. People were just doling out pills and sort of calling it a day. And that certainly didn't address anything in my life other than the absolute sort of physical necessities, but the underlying sort of things were became a real part of assessing what a treatment plan would look like for me, and this resulted in me really starting to kind of trust this person who helped me through some of the hardest times of becoming sober, of finding resources for my mental health, and for delivering the news that I was indeed living with type 2 diabetes. So there was a plan that I took seriously, that I followed, in order to kind of like incorporate physical exercise and a better diet in my life, as well as sort of dealing with the issues of depression, right? And it seems as though all of these things have helped me to kind of learn a bit about the trauma that I experienced as a kid, that have that I've carried for all of my life. So that's kind of how diabetes is for me. It's part of a larger sort of equation, and being able to sort of tap into the different areas of my life, diabetes just sort of being a part of that, has resulted in my ability to kind of control it a little bit better these days.
I'm muted. Not only are you controlling it, but you're also doing incredible things. You are a triathlete. You were just featured in Triathlon magazine, which was incredible. Your art is all over the place. It's been wonderful to see that. And you're also working and engaging the community by being a patient partner and doing other things to really bring your story to the community and to inspire and help others. So what was it that made you want to become a patient partner?
I remember back in 2017, an Indigenous fellow by the name of Brian Sinclair died in the Health Sciences Center in Winnipeg, back home, after not being seen by a doctor for 34 hours. The assumption was that he was one of these drunk Indians that healthcare practitioners seem to have this obsession over stereotyping people as, right? So that's why in BC in 2020, the report into how racism within the healthcare industry pointed to 84% of Indigenous people who come into contact with healthcare in this province were dealt with, in a racist manner. So I can speak to that, right? That's been my experience as well. And so for me, I think that healthcare is tremendously important. We still have this epidemic of, a lower life expectancy because of colonization But I do think that there is a way out of this. And as much as I love to point out the negative, I do love to point out the positive as well, you know? And I think that establishing relationships built on trust and respect are really important when it comes to health and wellness. And certainly, I think that some of us actually being invited to share our experiences kind of help to understand some of the underlying issues, right? And if we're being treated, you know, seriously and with, you know, um, good intentions, I think people can start to trust the experience of the healthcare system. So for me, I think it's important that I play some role in that, in sort of being able to say with some confidence and experience that it's it's possible to receive quality healthcare on parity with non-Indigenous Canadians. It's going to take some time for people to sort of adjust to the fact that we're human beings as well, for some reason. Um, but I kind of have had a very good experience, you know, and so seeing familiar faces, yourself and Tracy and people on a fairly regular basis, I think it's really important, you know, that these relationships occur. And um, so this patient partner thing, I think, is a reflection of the desire and the need for change in this country.
Yeah, and we are certainly lucky to have people like yourself who want to help improve the healthcare system and make these changes for everyone. And one of the questions, and I'll make this the last question because our time is going so quickly. What research are you most excited to be a part of? What kind of projects are you hoping to be involved with or excited to be involved with?
Yeah, thank you. I mean, I do triathlon for fun and for exercise and for a hobby and just to sort of push my limits to sort of see what my limits are. I still don't know what they are. Um, but I don't think that that's necessarily what, I mean, that's certainly not what a person, you know, looking to manage their diabetes has to do in order to be well. Um, I'm interested in sort of making sports, you know, accessible to young people and to people looking at, you know, improving their health to make, you know, better choices, to understand kind of how to manage type 2 diabetes. So anything that, you know, involves, you know, maybe some cycling or, you know, some of the traditional sports like lacrosse or, uh, you know, some of the things happening in track and field. I'm really excited about, you know, seeing other Indigenous athletes out there, people who are, you know, engaged and who understand the mind, body, and spirit sort of way of doing things in accordance with the Anishinaabe medicine wheel that, you know, elders have been trying to beat into my head for a long time. And one day I'll have a better understanding of it. But for now, I think it's important for me to sort of be able to share the idea that, um, you know, there may be no money in the cure and all the money's in the medicine, but there's things that we can do in our lives right now today where we can take control of our lives. And so any research into making healthcare accessible and recreational activities accessible is certainly the most interesting things for me to contemplate.
Wonderful. I appreciate so much you sharing your story today. And thank you again for that. And I will welcome our next guest. So thank you. And oh, there we go. There you are. Looking for everybody on the screen. So first we have Ron Bellino, who is an active advocate for dementia, caregiving, aging, and research communities. As a caregiver to his father, who lived with Alzheimer's for more than 10 years, Ron utilized technology, community, creative strategies, and access to research to support his family to live well. In recent years, Ron has been invited to presentations locally and internationally for the Alzheimer's societies, communities, police, educators, innovators, and corporations. He shares his knowledge on caregiving as we age, ways to use technology for caring, and living safely with dementia. And he is active in so many organizations. And Ron, we're so excited to have you here. He is also a Diabetes Action Canada patient partner. And Rebecca Ganon is well, I will read your bio. Dr. Rebecca Gannon first joined the School of Nursing at McMaster in 2006 as a part-time faculty member and became a full-time assistant professor in 2017. She teaches in both the undergraduate and graduate programs. She is co-scientific director of the Aging, Community, and Health Research Unit, the acting lead of the McMaster Collaborative for Health and Aging, and the lead of the Primary Healthcare Patient Expertise in Research Collaboration. She's also a researcher at the McMaster Institute for Research on Aging, and her research is focused on integrated health and social service delivery innovations to promote physical and mental health and mobility among community-dwelling older adults. So I will let you guys share your slides, and I look.
Thanks so much for your introduction, Chris. I'm so pleased to be here with Ron. I just want to pause for 1 second before I share the presentation. And I just want to say to you, Mike, I have not had the privilege of sharing space with you before. And so I really appreciate you sharing your powerful story, your experiences, and it's really inspiring and thinking about your capacity to move forward in the context of experiencing trauma. And I just really appreciate that. And I thought you had really powerful messages around, building relationships based on trust, understanding the impacts of systemic racism, but also highlighting where there are positive experiences and opportunities for quality care for all. So I just couldn't let that opportunity pass before without acknowledging. So Krista said more than I planned to about myself, so I'm going to turn it over to you, Ron. I'm just going to start sharing our slides here.
Sounds good. And as you pull that up there, Rebecca, thank you there, Mike. As a fellow patient partner here, our voices are quite powerful. I know that. But when you get another patient partner that has this huge voice that you have, it just gives me fuel as well to keep going. So we cheer for each other. We cheer for everybody. So thank you there as well. So greetings, everyone. I'm Ron Boleno here, and I'm going to kind of share a little bit of my part here before I pass it back to Rebecca as to my journey, but also kind of the journey of possibly many patients as they go through this space of simply just taking care of their lives to kind of getting engaged with research and other projects along the way. So that's me there. I'm a photo with mom and dad. My dad's Ray, and my mom and dad both live. My dad passed away already, but they have diabetes, or they've lived with diabetes. Coming from a Filipino community, it's quite high in our community. So even just that cultural piece is something that I can bring to the table. So for me, it always starts with a story and to understand our story. So Mike, for example, shared his story, his impactful story, and everyone has their own. For me, again, there's mom, who her name is Ronces. My dad's name is Reynaldo, and Filipinos have this habit of combining their names, and that's what you get. You got Ronaldo, just like that soccer player. And part of our family as well, Lucky the cat, peacefully passed away about a year ago after 20 years, but was part of our care team as well. So that is also part of the story. And during the time that my dad lived with his Alzheimer's, from his diagnosis in 2007 to 2018, we're just going about our lives, living in it. Me as the caregiver, caring for dad as best as possible, while also caring for mom along the way, the primary caregiver who lived with my dad. Eventually, even prior to that, dad was diagnosed with his diabetes that we didn't realize actually possibly supported us in finding out his diagnosis with dementia. It was a diabetes incident where we had to go to the hospital, and he was close to having his leg amputated. But then that's where they caught that, hey, I think your dad has dementia. So that was kind of a little bit of our journey in that diagnosis there. Medication was an issue. I'm going to bring that one challenge up. I think they realized, they said, how come your dad's not taking his medicine, or is he taking too much? And I said, we don't know. We didn't realize that. We just left it up to him. But then they said, I think you got to check and be on top of this, because he's not remembering some of the stuff we've asked him. So that's what we started with. Along the way, I've used technology, some pill machines that you're going to see in a few minutes here. And as we kind of went through that challenge, I started realizing that, hey, we got to get better at this. We were having some issues, and sometimes I didn't get the answers that I needed, or they weren't as good as what I wanted. So we're going to shift to the next slide here, and you're going to see an example of something I always like to talk about is the stories become challenges. Okay, we're living with challenges. And here's an example of a video. I didn't put the audio in here, but it's just simply my dad using a pill machine to take some of his medication. For us, that was a big deal. It was something that at that time, for about maybe 3 to 5 years, he could manage his medication on his own. But without that pill machine, without the support of Lucky as well, without my mom filling up, the pill machine that will make it easy for us for about 2 weeks, it was actually quite challenging. And that's just an example of challenges that we deal with. And along the way, we also deal with failures. As patients, if we weren't dealing with failures, if Mike wasn't dealing with some of the failures of some of the trust that he had with in the past of maybe healthcare, the healthcare community of whoever he was working with, I count those as failures. But then there are those successes, and it is one where we have to remember that, hey, where are we succeeding and how can we get better at this? So it's one where, for me, it's simply, this ability that patients actually grow to dealing with all these challenges, failures, and successes. And then some of us, our voices get much louder. We start actually either, it can come out as a complaint, it could come out as investigation of asking questions. How come we're not doing this? Or how come there's no solution for this, which we can get? How come policy is set up this way? How come I can't afford it? Or how come they can't afford it? Things like that. The voice gets louder, and that's the beginning of advocacy for many. It's one where, for example, advocating for my mom, okay, to make sure that the doctor kind of gets her medication to her on time. Sometimes there's that delay at the pharmacist. Oh, the doctor didn't call it in yet, and it kind of just killed our time. As Tracy said, respect our time. That's a big deal. So that is something that the voice of the patient gets louder. And then Rebecca, next slide, please. Yeah. And then as that voice gets louder, we then eventually want to make that impact, and we become advocates. As simply as either sharing your voice, sharing those stories, and then contributing it into the proper space, which could be, for example, for me, that would be Diabetes Action Canada. That's one space that I've connected with here. I'm sharing my story. Someone here is going to hear, okay, we got to get better at this, something that Ron said or that Mike said, that, hey, we could improve upon that. So for me, the first research team that I got connected to was AgeWell, known as Canada's Technology and Aging Network, where I helped set up the voices of older adults and caregivers. So we have an advisory committee across Canada that I chair, and that's one where that has expanded. So there's about 3,000 to 4,000 voices that we have that are part of AgeWell, sharing their opinions on innovation, technology, solutions about aging. Here I got connected to Rebecca over at McMaster there, and it is with pronounced a crew there. And it is something that I'm quite enjoying in the community. So in Scarborough, I've supported some of the work that's happening in my local community, being on a community advisory board on diabetes with Rebecca as the lead researcher, and just a few other organizations that I'm with as well here. One is SPORE. For those who aren't familiar with it, that's strategy and patient-oriented research that you could look up through the CIHR, Canadian Institute for Health Research, which is about patient-oriented research and also supports Diabetes Action Canada. So those are just a few of the places that I've connected to. I'm not your typical patient, unlike Mike as well. He's not your typical, I think, patient voice. We're quite strong. But yeah, that's the power of one voice. And that's kind of how I ended up here today and working with the wonderful Rebecca Ganon here. So Rebecca, I'll pass it over to you.
Thanks so much, Ron. You're too kind with your words. It's a pleasure to work with you, and I enjoy it every time we have the opportunity to work together. So today, I'm going to just really quickly in the next few minutes tell you a little bit about the ways that patient partnership, Ron and other patient partners that we've had involved in our research program have helped us to plan, execute, and evaluate our research program. Help you to think about how patient partnerships can help identify scalable and equitable models of diabetes care. To improve quadruple aim outcomes, so patient outcomes, patient experience, provider experience, and health system costs. Learn about the implementation of our pan-Canadian patient-driven and evidence-based model that's designated to address some of the gaps that we've heard from patient partners related to diabetes care delivery and improve outcomes. So, just to remind you, this is about ACRU, as Ron said, the Aging Community and Health Community Partnership Program for Diabetes Self-Management for Older Adults in Canada. I'm going to blow through the next couple of slides, so please do reach out if you want more information. We have a very large interdisciplinary research team that is led currently by my colleague, Dr. Maureen Markle-Reed, who co-leads our research unit, and Jenny Plow, who has recently retired. And we have co-investigators, but what I want to highlight for you on this screen is we have policymaker partners and we have knowledge user partners that are co-investigators on our research study. They've been involved since the program development and have been involved throughout. And highlighted at the bottom is also, as Ron said, our community advisory board members. So we've had community advisory board members who've guided implementation at a site level. So we had 6 sites in 3 provinces, and they helped to guide local level implementation. So I just want to acknowledge the team. We have very generous funding support through the Strategy for Patient-Oriented Research and through Diabetes Action Canada and other really important partners that I won't go through naming that are here. I also want to acknowledge that we've had funding from policymaking partners across each of the provinces as well, which has been really, having those policymaker relationships has been critical to success. And we've heard lots of times from patient partners how valuable it is and the opportunity that they desire to inform practice and to inform policy. So where we have these multi-stakeholder groups within research, they're really important and powerful opportunities. So why do we focus on older adults with diabetes and multimorbidity? We know that the prevalence in older adults, at least in Ontario and in other areas, is about 22%. And that many live not only with type 2 diabetes, many live with people with type 1 diabetes are living longer as well. So we're seeing more older adults living who have been long time type 1 diabetics, but we're also seeing about 40% of older adults with type 2 diabetes that have multiple chronic conditions that they're managing. And we know that that's extremely challenging for people in terms of managing their own health, and there are lots of risks associated with it. And there are lots of challenges associated with the existing care delivery models in terms of offering integrated care, and that some of the guidelines that can inform practice are organized around single conditions, and there's not a lot of emphasis around the social determinants of health. That's changing a bit, but still concerning. So I just want to give you a little bit of a backstory around where we are, because right now we're talking about this multi-provincial start, but where it began was actually at the very beginning of this, and this was where Dr. Markle-Reed really led this work, was a local seniors organization reached out to her, and some of the older adults in their community were identifying that they were having challenges in managing their diabetes and needed some self-management support. And so that started with a workshop with a variety of stakeholders through that sort of local site. There was a pilot site, so one site in Ontario for a feasibility study, and with some promising results around making some important impacts in terms of diabetes self-management. From there was a pragmatic, so real world implementation trial in Alberta and in Ontario. And from that, again, building that evidence base to say that this is effective in different populations and settings. And then right now, we've just wrapped up the pragmatic randomized control trial that was happening in 3 provinces, so in Ontario, Quebec, and Prince Edward Island. And we've just finished our time to interviews for all of those participants. And so we were able to test it amongst more diverse populations and settings. So looking at different models, and I'll tell you a little bit about that, and also looking at reaching more diverse populations. And so as Ron said, one of those settings was in Scarborough, Ontario, which if you're not familiar with it, it's highly diverse, really lots of ethnocultural diversity, challenges also for some in terms of determinants of health as well, in terms of socioeconomic inequities as well. Our downtown Toronto site, similar kinds of challenges. So people aren't just dealing with health complexity, but also dealing with social complexities in some cases, and some barriers to accessing appropriate care in alignment with their needs. I just want to also say on the left-hand side of your screen, you see that continuum of engagement. And I put that there because I think as we reflect upon it as a research program, where we started was about people informing, and we were consulting with people for input, but really we have evolved and we are collaborating with partners, and people are embedded throughout our research program. So I'll tell you a little bit more about that in just a second. So some of the key strategies or components of the ACRU Community Partnership Program are a focus on person and family-centered care, strengths-based approaches. So that resonates, I think picks up on some of the points that Mike was talking about and that Ron has talked about, thinking about people holistically and thinking about their physical health, their mental health, but also their social context and the determinants of health, bringing together a circle of care, so a registered nurse, a registered dietitian, and a community partner. So this was delivered in partnership with community organizations. There were individual components that were delivered to participants, but also a group-based component that promoted sort of healthy living, physical activity, healthy eating, connecting with others socially, those kinds of things. So we had those integrated partnerships with health and social services, and looking at tailoring and adapting the program to individual needs. So tailoring to the individual, but also adapting to the local context and leveraging those community resources that were around. And it was also always designed with scale up in mind, so that it would be a scalable program that could be implemented in other communities. So I'm just here we were looking at also in this program of research, identifying high system use. So what characteristics were sort of drivers or associated with high system use? So people who were more likely to use emergency room departments, increased rates of hospitalizations, a variety of ways of looking at that. We were also looking to co-design those adaptations in other communities and with other people. We were examining in the trial, not just how effective it was, but also looking at how it was implemented in these different sites and how it was adapted to diverse populations and settings, and also exploring patient, caregiver, and provider experiences with the CPP. And I said about scalability already. So one of the things I want to shift to in just the last couple of minutes, I think we have a minute or two, I want to just talk about how we have engaged people within this research program. So we really have looked at it with a multi-layered approach. And what you're going to see here is our governance structure. So we have had patient partners that are involved in our steering committee, and you can see the different roles on the right there, in our local community advisory board in each of the sites. And also that high system user study that we had at the beginning, we also had patient partners who were part of that working group and embedded throughout. So patient and public engagement was, you can see in that black circle around, was all the way throughout the research program. Integrated knowledge translation throughout, capacity building amongst all team members, including our patient partners, with a goal of system transformation. So some of the ways that we engage people, and I think about Tracy's diagram that talked about the stages of research. We engage people in grant development. We engage them throughout that governance model. Ron was part of a co-leadership model. So he co-led our community advisory board in Scarborough, and we had a similar model across our sites. There were study-specific engagement activities. People were involved in shaping the implementation of the trial, but also how we implemented our engagement strategies and with what impact. So we evaluated the impacts of engagement. And we also have had, I've had some opportunities to co-present with Ron and with others. You can see a couple of our other patient partners here. Frank, who's one of the members of, one of the partners of Diabetes Action Canada. We've co-authored publications and also other sort of friendly documents, infographics, those kinds of things. So I won't go into detail about those, but we've really tried to embed and engage partners in alignment with their interests, in alignment with their capacities and their time, because these are, often many of them are very busy people. So in alignment with their interests and availability and leveraging their strengths, I would say. So Ron, I'm going to turn it over to you for some words around challenges and some of the insights that we've gained.
Yeah, so for us, one of the key pieces is, I said the word earlier, challenges. And for me, it was simply just the ability to really make sure that the community and the research team, really get to understand even just something like language, like words, and the diversity piece. Language can go a long way and that ability to communicate is one of the challenges I'm going to throw out. The finding and engaging vulnerable populations. Again, we mentioned Scarborough as one of our communities that we worked with, and that ability to really be embedded. Some of the patient partners are embedded in that community, like Mike himself, is one of those things that you have an advantage of actually having a patient partner on your team with. And then advancing the science of patient engagement. So for me, that is the ability to take it to the next level, to create that impact. Impact is a huge word that I love to use. And that piece where you take the work and the ability where we trust your work. Okay, so Mike, you mentioned that earlier, that's huge as well. So that's, yeah. And then the resources and funding, I can't recall what I was going to share on that there, Rebecca.
I think one of the things there, sorry, my mouse is making this glitchy, so I'm sorry it's advancing on you. I think one of the things that I wanted to say there was that none of this engagement work could be done without sufficient funding. So you have to invest the time, you have to invest the resources, you have to have dedicated leads. And we have a sort of established sort of role negotiation and an honorarium for the time and expertise that our patient partners bring. So I think that that's a critical piece for people who are engaging in this kind of work.
And Rebecca, if I can just add, for Diabetes Action Canada, it's, to me, they are the leader organization that research group that actually, and there are others are coming up, other networks that are doing this, but to be able to have the resources for the patients that Tracy said earlier, that there's always something contributed back to the patient partner is huge in my opinion. So Diabetes Action Canada is one of the leaders as well. I'm going to throw that out.
Yeah, I agree for sure. I'm just going to end on a couple of quick quotes from some of our other partners that we've heard. Just let me get there. So, why is this being glitchy? What just happened there? My apologies. So I'm just going to leave it there. I'm not going to fiddle. So this is from one of our partners. I appreciate the team's inclusive of the patient voice at all levels of project design and this idea of patients as equal partners and that it's really person-centered. So our intervention is person-centered, but we parallel that in our engagement strategy. I think as well, so this is another quote, I think as a patient, I'm encouraged, not that our stories are being used, but that our stories are informing a sense of urgency and importance of this work. And then this was from a new patient partner, so someone who isn't as experienced as Ron in all of these different venues. And this person said that it's encouraged them to try to learn more about participating in more studies and grant proposals and system research designs. And they felt that there's an authentic process and meeting people with lived experiences where they're at is really critical to this work. So I'm not going to tell you about that. I'm going to leave it there. Please do feel free to reach out to Ron or I if you'd like more information, or you can certainly go to our website for ACRU. And we also have a page on Diabetes Action Canada because we're one of the working groups with Diabetes Action Canada. So I'm going to stop sharing now. Thank you for your time.
All right, thank you guys for that. That was awesome. And we're running a little short on time, which is okay because we had a great conversation. But I wanted to acknowledge, because I know a lot of people will be watching this later, there have been quite a few questions about how to get involved with Diabetes Action Canada as a patient partner. You can go to diabetesaction.ca and there's a section there called Patient Partners. So you can get involved that way and find out more about that. We also have a question, Tracy, we have a question for you about whether or not this is something with whether it's all research or whether there can be dialogue in prevention, remission, management of diabetes, if that's something that is also part of Diabetes Action Canada.
Thanks for the question, Kristen. I did see that in the chat. I think, as long as it's a patient identified priority, Diabetes Action Canada is there to help. And we really do focus our efforts in research because that's an area where we can really make impact. But if we're approached for other initiatives, especially where patient partnership would be really beneficial, then we will definitely participate.
And I wanted to thank every single person who has participated today. It was really, really wonderful. I know we're just out of time, so I'm going to send it back to Kelly, but thank you to everyone. And if anyone does have questions, info@diabetesaction.ca is where you can get those answers from us. Thanks, everyone.
Thank you, Krista. So thank you so much, Tracy, for getting us started with the context and understanding more about Diabetes Action Canada and how you engage patient partners. I think those do's and don'ts that you started off with will really resonate with people and are good lessons learned for others who've been listening. And thank you so much, Mike and Ron, for sharing your stories. They resonated with me for different reasons. And it's so great to have you here today to share that with us. And thank you, Rebecca, for letting us know how you engage patients in your research. Yeah, so I'm going to take some time to reflect on everything that I heard today. I learned so much, so I'm grateful to be with you today. And I think my takeaway is, to build a better healthcare system, we start with relationships built on trust and respect, and having patient partners at the table. Without you, I don't think we'll be able to build a better system. So it's 2 o'clock on the nose. I wanted to quickly just let you know we do have some poll questions that we ask at the end of every webinar just to get some quick feedback. So those should be activated. We would like to know if you learned something new at this session, if you'll be able to apply this learning in your work, and if you would recommend this session to a colleague. So if you could just take a few minutes to quickly, or a few seconds to quickly answer that, that would be great. I also want to remind you to, if you haven't already, please join the Type 2 Diabetes Network. And I think Donna's going to put the link in the chat if she hasn't already. And the next webinar for the network is taking place on June 23rd. And that focuses on Indigenous self-determination and equity in diabetes. So thank you again for everyone who joined us today. And thank you again to our speakers. We're happy to be able to provide this venue for you to share your work and your learnings. Take care, everybody, and we'll see you next time.